Infection control in operation theatres. Surgical care is an integral part of healthcare throughout the world, with an estimated 234 million operations performed annually. Surgical site infections, or SSIs, remain one of the most common causes of serious surgical complications. They account for 14% to 17% of all hospital acquired infections and 38% of nosocomial infections in surgical patients. The risk of developing SSI varies greatly according to the nature of the operative procedure and the specific clinical characteristics of the patients undergoing the procedure. Potential patient-related factors include malnutrition, old age, coexistent infection, and diabetes. External risk factors include the type and duration of operation, surgeon skills, the quality of preoperative skin preparation, adequacy and timing of antimicrobial prophylaxis, insertion of foreign material or implants, inadequate sterilization of surgical instruments. The rate of surgical wound infections is strongly influenced by operating theatre quality too. A safe and salubrious operating theatre is an environment in which all sources of pollution and any microenvironmental alterations are kept strictly under control. This can be achieved only through careful planning, maintenance, and periodic checks, as well as proper ongoing training for staff. Structural features. The structural features of the operating unit can influence not only the efficacy of the treatment provided, but also the outcome of the patient in terms of the prevention of surgical infections. The design of the operating unit is complex and requires that different areas be correctly integrated. In addition to keeping clean and dirty areas separate, it is important to ensure that patient flow from arrival to discharge is orderly and logical. Specific rooms should be designated for performing surgical procedures and for processing instruments and other items. It is important to control traffic and activities in these areas since the number of people and the amount of activity influence the number of microorganisms that are present and therefore influence the risk of infection. Restricted entry is extremely important. The operating unit should be arranged in progressively less contaminated areas from the reception area to the operating theatres. Moreover, organizational or functional and/or structural intervention must be implemented in order to ensure that dirty and clean pathways be kept separate. The size of storage areas for dirty material, clean material, supplies, instruments, equipment, and drugs must be determined in accordance with the type and volume of activity of the operating unit. Moreover, in designing an operating unit, the choice of surface finishes, structural features is of great importance. Surfaces should be easy to clean in order to facilitate infection control. Design, layouts, fittings, furnishings, floor coverings, and finishes will have a significant impact on the cleaning of the unit. Ledges, corners, and all other surfaces that is difficult to clean should be minimized. The surfaces of floors should be impervious to moisture, easily cleaned, stain resistant, comfortable for long periods of standing, and suitable for wheeled traffic. Window frames should be designed in such a way that their surfaces are easy to clean and do not collect dust. Cleaning and fumigation. Cleaning of operation theatre should follow guidelines mentioned for patient care areas. Dedicated staff should be supervised for cleaning activities. They should wear appropriate PPE while cleaning. A high-level disinfectant is diluted as per manufacturer's recommendation. It is used for cleaning and disinfection of surfaces, for example, the OT tables. Always use clean linen preoperatively. Fumigation with formaldehyde is not recommended since it is toxic. Alternate methods of fumigation may be used with commercially available chemicals. Always follow manufacturer's recommendations. Appropriate procedure needs to be followed for fumigation, keeping all doors and windows closed, keeping all staff and patients out from the fumigation area, and may be done on holidays or when the OT is non-operational. Ventilation. During surgical procedures, dust particles, textile fibers, skin scales, and respiratory aerosols loaded with viable microorganisms are released from the surgical team and the surrounding into the air of the operating theatre. Bacteria settling on surgical instruments or entering directly into the surgical site may result in surgical site infection. Therefore, maintaining a high quality of the air in the operating theatre is essential to controlling the risk of surgical infections. In this regard, a fundamental role is played by the contamination-controlled airflow system like heating, ventilation, air conditioning system, etc. Indeed, in addition to maintaining temperature and humidity at optimal levels, this system provides ventilation that is able to keep the concentrations of gaseous pollutants, particulates, and airborne microbes below predetermined levels. The air in operating theatres should be kept at a higher pressure than in corridors and adjacent areas. This positive pressure prevents the flow of air from less sterile areas into more sterile ones. With regard to ventilation, various international scientific organizations recommend a minimum of 15 air exchanges per hour.
Infection control in operation theatres. The water distribution system in hospitals may constitute a source of healthcare associated infections caused by opportunistic pathogens such as Pseudomonas aeruginosa, Stenotrophomonas martophilia, Burkholderia cepacia, Acinetobacter species, and fungi. Taps are common sources of Pseudomonas aeruginosa and other gram-negative bacteria and have ever been linked to infections in multiple hospital settings.
Immunocompromised patients are particularly susceptible to infection caused by waterborne microorganisms, which can cause bacteremia, meningitis, urinary tract infections, and surgical site infections. Surgical hand antisepsis with medicated soap requires clean water to rinse the hands after application of the medicated soap. Procedural and behavioral factors. A behavioral approach aims to reduce the number of airborne particles in the operating theatre through disciplinary measures. Simple and cheap measures include limiting the number of personnel in the operation theatre and restricting the movements of personnel in operating theatre to a minimum, as it has been shown that increased activity facilitates the dispersion of bacteria. Change the clothes before entering operation theatre. In addition to the number and movements of personnel in the operating theatre, adverse surgical events may be due to poor communication, bad operative technique, malfunctioning or improperly used equipment, and cognitive errors due to stress or inattention, all compounded by resource and organizational problems. It is important to emphasize that all personnel working in operating theatres, including surgeons, operating theatre assistants, anesthesiologists, and cleaning personnel, must follow hygiene protocols very strictly. Elective surgery on infectious TB patients should be postponed until such patients have received adequate drug therapy. When emergency surgery is indicated for a suspected